So for the many people in this room who actually know MOHT and know me well already, and you've heard this talk many times, don't worry. I've put in a lot of good new things that I think should keep your interest. Mainly this talk will be a bit unusual from what I normally speak of because I'm going to talk a lot more about strategy. The strategy of MOHT, population health strategy, and what role digital phenotyping can play in that strategy, even beyond mental health. Most of what I talk about will be mental health, but even as you branch beyond, let's say in wellness or aging, right, a very key national priority right now. So I should say, with that said, a lot of these ideas, a lot of them are my interpretation of what's going on and sort of my views. I think they should largely reflect what people at MOHT say, but I should make that clear, and I'll try to make that clear. This is my view of what's going on strategically and what's strategically important. So yeah, my background is, my role as a data scientist, my background training is in machine learning. So that's where a lot of my biases of these perspectives come from. But I would like to maybe share a lot about the strategic thinking, and hopefully you won't get bored about it. I hope that it interests you, especially people who kind of consider themselves more scientists or engineers in this process. I have found strategic execution very, very fun. I think it's an enjoyable part of my job, and I hope that you get a lot of that out of here. So here's my plan. I'm going to tell you about MOHT, especially for people who don't know anything about us. We are a small organization, and what our strategy is. How digital phenotyping aligns with or serves that strategy, why we do it. We started in mental health at the Institute of Mental Health, IMH, where the HOPES clinical service now runs. But then after I talk about that, and that'll be my deep dive into our technical developments, I'll then branch back out to new areas we're going into, such as into wellness. So not diagnosed mental conditions. This is already happening now at Nanyang NTU, Nanyang Technological University, for those who don't know, in a trial with 500 students. They're all on HOPES right now. And then what's more new is our expansion into aging, or healthy aging, healthy longevity. Lots of unknowns. A lot of the point of this talk is to ask you questions that I do not think that we have a clear answer to, or I've not seen it yet anyways. What is the strategic value proposition of digital phenotyping in some of these newer areas, like in wellness and in healthy longevity? Some of these things I don't know, and I would like to get your ideas. So about MOHT, I should also monitor the time. We are the MOH Office for Healthcare Transformation. We are MOH's innovation partner, working at the system level, specifically on transformation projects. So we say partner because, believe it or not, we're actually not part of MOH. We're a .com spin-out of MOH. I put on the right here our KPIs, which I wanted to highlight because notably we are not a research organization. So we do live and die by research. And actually a lot of our activities look like research, but research outputs will never be our KPI. None of us get our performance evaluation or bonuses based on research outputs. So that is an important point about what drives what we do. Part of our focus on transformation, and kind of that's why we strategically select what we do work on and why digital phenotyping is attractive to us, largely tries to address certain things like Singapore's excellent performance in healthcare, good health outcomes at only 6% of GDP, but in the rise of large shifts happening in the population, such as growing burdens of chronic disease, the aging population, things that are observed in many developed countries, and things that are of interest and of focus of many transformation offices around the world. If you want to maintain that same performance, that same quality of care and health outcomes, under the growing burdens, you have to increase spend. You can no longer achieve that outcome at 6%. Your healthcare expenditure must reach 20%. The only way to avoid that outcome is to transform. You must transform care. Something radically different needs to happen underneath the hood. Otherwise, you have to either increase costs or lower quality. That's the formula. So that's why the office exists. It is part innovation, part change management. And we are guided by these national strategic priorities. So again, many people in the room, if you're based in Singapore, you probably know these well, especially if you work in healthcare. I understand some people are not working in healthcare, so maybe this might be relatively news to you. Healthier SG, our national strategy to refocus on preventive care, prevent chronic diseases or manage them, particularly by refocusing that care on the primary care sector. Age Well, which is our strategy to help seniors age well in their communities and at home. We are, of course, guided by these national strategies. So now think about it. For those who already know what digital phenotyping is digital phenotyping an enabling technology that can transform care in under these two priorities? For some, I think the answer probably is yes. For some, I'm not really sure yet. Some elements that we think are required for transformation or that we see is, these projects, they have to be national. So any solutions we develop, they got to scale nationally. Two, they have to represent good value. So you can't just improve health outcomes. You have to do it at a cost-effective or cost-attractive way. And it also has to provide a step change. It should not really be an incremental. For it to be change management, it really has to kind of be a large change. And so the office should have some reasonable appetite for risk. And then finally, a key theme that is relevant to digital phenotyping are themes that, again, transformation offices around the world are focusing on. Increasing the continuity of care from episodic clinic-based care, right, every 6 months if you're a hypertension patient, to care at all times, in the community, at home, when you're sitting on your couch, every 5 seconds when your Fitbit's pulling out HRV reading off your wrist device. So constant data communication and care with the clinic. That is also aligned with the strategy to shift care away from the hospital into the clinic, into the community, into the home. We call it the shift left. And also the transferring of the locus of the burden of care from the clinician onto the individual. That really is the only way. Moving towards prevention, health promotion is how you're going to move the needle. So with this in mind, national priorities, how we set our MOHT-wide strategy, it is no surprise that digital phenotyping, that was one of the emerging trends around the world in technology and in healthcare, caught the attention of the office. So there are many pioneers in digital phenotyping. One of the ones that we look to a lot is a team at Harvard who developed much of this strategy in psychiatry, and their choice for mental health, there's a reason for it, developed the Bayway platform. That was published in 2016, but probably even before that. Here's the definition that we still use today. Digital phenotyping, for those who don't know, but I assume many people already know what I'm talking about, the moment-by-moment characterization of your individual level human phenotype in situ, right? So as you go about your daily lives, by constantly recording data from passively recording data from your personal digital devices. Another, for example, just to give you an idea of what the buzz was like, Tom Insel, the former National Institute of Mental Health director in the US, he even visited Singapore and met with a lot of the healthcare ecosystem leaders. He had a large influence on convincing MOHT that we should invest in this. This is a technology we should get involved with. In fact, so much so that he went and started up part of the starting founders of a company in the US called Mindstrong, which was a digital phenotyping company for healthcare, mental health care. I purposefully selected a screenshot of this article, which was about its failure, Mindstrong's failure. Not necessarily because of the science and the availability of signals, but for many reasons why it's hard to deploy these things, business models, many other reasons. We are facing those same challenges at MOHT. We're not a research organization. We have to deploy these things at scale. And yeah, if we don't solve those challenges, which we're battling every day now, then we would head down the same path. So we started out, when we decided to enter digital phenotyping, just about the time I was joining MOHT actually, we started out by developing a platform. Not that you always have to develop a new platform or app, but in this case, we needed some new features. Namely, we forked Bayway, which was the Harvard open source platform, to develop HOPES, which is our digital phenotyping platform, co-developed with IMH from the beginning. IMH was the clinical partner who said that they wanted this, developed it with us from the start, and they co-own the platform. Principally, we integrate both the smartphone and a wrist wearable device. Bayway only used the smartphone before. We really wanted both. At the time, we really wanted it for more research reasons, right? Exploratory analyses, all the different signals. What was the multivariate signal that was strongest? That's kind of the idea at the time. But actually, it turns out that was a very valuable thing we did for reasons we did not foresee. For example, from the wrist device, some patients right now in service, outside of research, right? This is real service. They're not incentivized. You just try and get them to use it. Some patients just do not like wearing that Fitbit. Certainly not to sleep. You just cannot get them to wear to sleep, and sometimes not even throughout the day. So for those patients, yeah, we just can't collect that Fitbit data. Good thing that we have the smartphone data that we're still collecting from them. At least we can still try and use signals from there, predict the things we want from there. Other scenarios, like Apple. Apple, the sensor data collection is only allowed through SensorKit. Most of the data you can collect from it. SensorKit is a research platform. If you don't have an IRB, they won't let you collect it. We don't have an IRB. This is not research, so there's no IRB here. So all patients currently on our service who use an Apple phone, we have no smartphone data from them. We only have wrist device. So for them, we really got to get them to wear that wrist device. In fact, we really have to get them to wear it to sleep. Because in schizophrenia, which is one of the major conditions that we're trying to address, for example, your sleep stages, your patterns of your sleep stages are the most valuable thing for us. Changes in that is very predictive of your state. So if they don't wear it to bed, then kind of for them, we almost have, we have very little. We have very little. So turns out this multimodality ended up becoming very, very valuable for us. Here are some visualizations of the key data sources that we're interested in psychiatry. Sleep, including sleep stages, heart rate variability. Sociability indices, very important for mental health, right? How much is a patient socializing in mental health? That is very predictive. Now, for the purposes later in my talk, when we think about other areas like aging, if you think about healthy aging, yeah, probably sociability and how that's changing in, let's say, an aging senior, perhaps living alone, could be a very useful tool. Geolocation, one of the most powerful predictors in mental health. That's the finding of many teams around the world, Harvard to begin with, and many other teams have found that geolocation from the GPS, the most useful thing for them. We see the same. It is the most predictive signal for us as well. However, the GPS is also a difficult one to collect. Many patients, in fact, we have this data, we know. It is one of the main reasons that patients reject our service, is the perceived intrusiveness of that data collection. Even though we have many mechanisms in place to say that we are secure, we're handling responsibly, it's well treated. That perception, hard one to break. Two, the GPS just devours your phone. So many patients on Android, you can turn it off, and most of our patients do, no matter how much you try and stop them. So this is another one that's difficult. So here's another problem that we've been working on. For example, what about you can come up with proxies? Actually, with the GPS sensor, most of what we're interested in is, did the patient leave the house? Right? So you can perhaps try and use the ambient light sensor. Immediately once you step outside, especially in Singapore, that sensor will saturate immediately. We also try and develop machine learning algorithms to predict whether or not they go out of home from a research data set. So in service, we don't have to collect that GPS data. We can instead just predict whether or not they went out from the house using things like accelerometer, pedometer, things like that. Another interesting one, tapping speed. It's a very powerful signal, not our finding, other people around the world found tapping speed very predictive of changing cognitive functioning and thus predictive of mental health state in mental conditions. We see this in our data too, and so on. Okay, so right now, this is a one-slide overview of the HOPE's clinical service currently running at IMH. So we collect the digital phenotyping data from the sensors passively at all times, as I showed you on the last slide. We also add in other things like, people call them ecological momentary assessments, just surveys, prompts that you send over to the phone, asking them, how are you feeling right now? What's your mood like? You spin it on a dial or you rate a slider, 1 to 10. All that data goes into our analytics engine. It's a bunch of clinician-defined algorithms supplemented by several machine learning algorithms. I'm going to show you details later. Those algorithms will then try and rank the patients based on detected need. That ranking will then populate a clinical dashboard that we developed with our clinicians. That dashboard is ranking the patients according to what the algorithms believe. And the care protocol is in place that the clinical care team member comes in every morning, looks at the dashboard and says, who are the 10 patients I need to check in on today? For those patients where there is a detected need, but probably not so severe that we think it might need a clinical team member, instead we just kind of send them a lower triage intervention, which is an automated digital intervention sent to them without a human in the loop, pushed to their mobile phone, directed by the needs detected by the digital phenotyping signals. A good example, simple example, if the patient hasn't slept well for 2 nights, push them a sleep CBT at 8 p.m. the following night, something like that. Okay, our goals, what are our goals? Yeah, pretty clear. Try and reduce relapses and rehospitalizations. Detect when patient state is degrading. Try and intervene early. That could look many different ways. bring them into the clinic earlier, review the records earlier, try and change the medication. I don't know. It's up to the clinical care team how they want to do that. But that's the big prize, but the very risky one. In schizophrenia, it's a notoriously hard problem. No one's really been able to show that even if you can detect relapse ahead of time and intervene early, that you could do anything about it, right? It might just be this physiological process that needs to run its course. Very uncertain, so we're testing that now. A second goal, really, and much of the theme of much work in healthcare transformation is about empowering the patients to self-manage their conditions, use these tools, monitor their own data, right? Nudge them when needed. Get them to be able to self-assess and self-refer when necessary. And then, yes, improve the clinician's effectiveness. It's important to note that right now, the clinical care team does not have any data right on the patient. All they have is just they can WhatsApp, they can text the patient every, I don't know how often you're going to text a patient. Maybe some you text every other day because they need you more. Some, months away. Even if you could call them every day and ask them how they slept the previous night, that's just not feasible, right? So that's sort of the point, the transformational point of digital phenotyping here. Okay, so how did we design those algorithms? Well, we collected a data set. We ran an observational study at IMH. 100 patients with schizophrenia spectrum disorders were onboarded onto HOPES for 6 months. That doesn't sound like a lot for many people running clinical trials, but actually there's so much data here. I computed it's over 80 million events. We believe this is the most comprehensive data set of schizophrenia phenotypes in the world. And in schizophrenia, this is a large cohort. So we do have here, I'm not going to go through it, but let's say, your typical longitudinal studies of associations of the digital measures here on the columns, all the different sensor measures against different clinical measures. In our case, in psychiatry, they are clinical scales measuring symptoms and functioning, how many hallucinations the patient is having, negative symptoms, depression symptoms. The point is that we do have many strong and clinically significant associations across a range of the measures and symptoms and functioning. And again, this turns out to be very useful. When you can't collect some of the data modalities, you can utilize others in its place. More probably important for the clinical dashboard are the machine learning algorithms that we have designed to try and predict adverse events ahead of time. So what you're seeing, I'm not really going to go into detail over it, but these are some prediction metrics of trying to predict adverse events, like when patients degrade and have to go back into hospital or visit the emergency room. And we're trying to predict those from changes in the digital phenotyping signals, so changes in their behaviors. This is the performance of a gradient boosting tree. Don't worry about it if that means nothing to you. Sensitivity is a measure of how well you're able to actually pick up those relapse events that are happening. Specificity is a measure of how well you're able to avoid false alarms. So our algorithms can perform pretty much on par with other algorithms that are out there, like for the Harvard team. We can achieve, like, let's say, a sensitivity around 87%, depending how you measure it, a specificity of 74%. Actually, some of the numbers on this plot look very good for some of the models that we use, astoundingly good. But you have to remember, that was a research data set. We financially incentivized the patients to collect their data. And it's a lot of data we're collecting, right? All those sensors. In practice, in service now, there's no financial incentivization. We just can't collect that amount of data. We collect probably 50% or less of the data we collect in research. So the algorithms, yeah, the performance will drop. That's one challenge that we're working very hard right now to solve. Here, for those who are used to looking at plots like this, or maybe Shapley value plots for the data scientists in the room, how many people here are like a data scientist or machine learning trained or AI trained? Oh, okay, good. Okay, so this is just a certain type of measure that tries to tell you which features were most useful for your algorithm to make its prediction, for the algorithm to predict those impending adverse events. And again, recreation of findings around the world. GPS-based measures, geolocation-based measures. The top ones are just how much you get out of the house and how much you travel around. Are you going to work? Are you going, to your piano lesson? I don't know. Regularity of your sleep start time. Again, very known, well-known, important signal in schizophrenia. Tapping speed. Again, decreasing tapping speed and cadence, a predictive function of cognitive functioning. So yeah, we find that in our data too. So all those machine learning algorithms predictions come in and help populate this clinical dashboard. So here, we have certain handcrafted signals from the clinicians. This was designed by the clinical team. But then we also have the machine learning algorithms that say and their predictions of which patients are doing poorly. And we just rank them every day. And the case manager comes in and they're supposed to go through it. It is adopting this red, yellow, green strategy. And one thing I want to note is that this strategy is a transformational one, we believe, because again, it is a completely reactive care model, right? You have to wait until the patient is feeling poorly, knows they're feeling poorly, and will call you or arrive at your clinic to a proactive care model where the data and the sensors are detecting their need in real time, and you can respond to it in advance, right? Early intervention. Okay. Importantly, for what I'm going to talk about later, the interventions, those digital interventions, some people call them digital therapeutics, ecological momentary interventions, maybe. That is delivered through our app. Much of the content is actually pulled from another database we have, which is called mindline.sg. It's our digital mental wellness platform containing tools like CBT, cognitive behavioral therapy, inspired exercises that are delivered through a chatbot, for example. And I'll talk a little bit more about that later. And what you should note is that now we started in schizophrenia. I showed you all that data in schizophrenia, but now we have been expanding. So here is one measure by percent contribution to DALYs, for example, disability adjusted life years. Schizophrenia is one of the larger ones, actually, in terms of your entire life course. We have moved from schizophrenia. Now we started recruiting patients with depressive disorders, like major depressive disorder. And then we have now moved on, and now we're actually offering the service to most patients at IMH currently. So the phase launch schedule happened over the past, I think we started in September of last year, 2024, with our current main service. Before that was sort of agile service development and refinement. So right now this is just hot off the press, 86 patients on service. We really need to ramp up to about 500 to 1,000 patients on service by the end of this year. And then probably by 2027, we really got to get many thousands of patients on this thing or it's in trouble. Its cost effectiveness argument won't be strong if we can't get to many thousands. We are around just the Institute of Mental Health. We can expand beyond IMH once we get HSA registration. So for those not from Singapore who don't know, HSA, the Health Sciences Authority, is the medical regulator here. Interesting fun fact, they have a policy that, so this is not research, right? No IRB here. So people might ask, like, how are you running this in a hospital if there's no IRB and you don't have HSA registration? Actually, HSA has this thing called people call it the single institution rule, where if you stay within one organization and some other conditions, actually then you can deploy these things under certain safeguards. So actually that's how we've been able to do that. If you were in another country, actually, there was no way we could do all this, right, in this fashion, in this agile fashion. You'd have to run your clinical trials in sequence, run your RCT. You couldn't develop during that study, right? During the entire IRB controlled study, you can't change your intervention. Well, it's hard to anyways, right? So you got to wait for that process, however many years that takes. Under this model, actually, we can rapidly be very agile, develop this very quickly. So again, I think Singapore, I'm not Singaporean, Singapore is a great place to do this thing. It is safe, it is ethical. There's many structures in place to make sure that we are being ethical, that we're being safe. Interesting fun fact if you didn't know. And we are pursuing HSA registration right now. To that point, for the AI people in the room, again, it's something you might find interesting. How does HSA kind of advise you to use your AI predictions in a clinical service? Well, one thing that is along their guidelines is our clinician-defined algorithms, really just rules-based algorithms. If patient sleeps poorly for 2 nights, do this. If 3 nights, do this. That populates the dashboard at first. If your machine learning black box algorithm then comes through and only pushes people up, doesn't relegate anyone down, it can only vote people up. This satisfies their guidelines for the use of AI in a medical device, software as a medical device, let's say. So that is very different from the FDA in America, let's say, which normally does not allow you to use machine learning algorithms that change its behavior, changes parameter sets in different ways, let's say in service. Those rules have changed in the FDA now, I understand, but point is that Singapore was also a little bit more of a liberal place, a little bit more allowing of experimentation with AI devices in healthcare. So that's also an interesting and useful thing for us doing innovation. We are going for HSA registration now. Actually, I shouldn't have written that. That's not really confirmed yet. We have discussed with HSA, but we still need to work out some details of how we're going to go for that. Very difficult and long process. So, I've given this talk several different times. And many people say, like, why do you care so much about digital phenotyping? Why are you guys putting so much work into it? Actually, this chart should kind of show you the reason. The contributions to your health, by one measure, premature death in this case, but there are other measures you could go by, and the factors that contribute to that. So, from a very influential article in the New England Journal of Medicine in 2007, there are others like it. 30% of it from your genetic predispositions. So that's your genes. The one data set you've given at birth. Maybe your epigenetics or your proteomics change over your life, at whatever rate they change. But by and large, bioinformaticians have been analyzing this for a good amount of time now, trying to reap the benefits of that as a data science problem. Only 10% actually comes from the healthcare you can access and receive and the quality you receive. That data would be in the forms of, let's say, electronic healthcare records. Again, clinician informaticians have been trying to model and analyze that for decades at this point. However, the majority of your determinants of health come from your behavioral determinants. And this is actually much more recent. People haven't really been collecting this in a systematic way in a healthcare context until much more recently, until that Harvard group started doing it and pushing it, really. So it is the majority. And that's why we care about it so much. We're trying to complete this circle. We're trying to collect an entire data on all of your determinants of health, come up with a holistic view of it and a holistic strategy to treat it. And also think about, multivariate signals, right? There's got to be an interplay. There's got to be, right? Not only that, but the definition, right? As I said, measured once. Maybe you can measure it a few times in your life. Gusto does this to some extent. It's a study being run in Singapore, for those who don't know. The EHR, okay, yeah, how many times do you transmit data to the clinic? Well, if you're my age, probably very, very little. Once you have a chronic disease, okay, hypertension patient once every 6 months, diabetes patient once a little bit more frequently. Now digital phenotyping has about reading off your HRV every 10 seconds, every 5 seconds off your risk. It is fundamentally a big data strategy. The definition of this data and the density and the frequency is massive. So anyone who does machine learning or AI in the room should immediately see this as an opportunity to flex their muscles, right, to get excited about. Obviously, this is where a lot of my work happens, since I'm the data scientist on the team. Okay, that's why we care about it. That's why it's strategic. So here's my question, and this is where now it's a bit of an open conversation. Afterwards, please come up to me with your ideas. My question is, what is the value proposition for digital phenotyping in different healthcare settings? So for one, let's say in research, for researchers, the value proposition is obvious, right? You want to do measurement, objective measurements. It's such a rich data source for you to measure. In fact, companies like Bayway started Bayway as a service company that you can go and you can pay them. You can pay them money and they'll let you use Bayway to help you use the open source code to run your study or collect your data or analyze your data. In fact, most of the people around Singapore who come wanting to use HOPEs are research teams, right? They want to use this. The value proposition is very obvious there. In wellness and health promotion, again, the value proposition must be very clear. Otherwise, these companies wouldn't exist. Aura, Fitbit, Apple Watch, they wouldn't be doing and being profitable at what they do. Google buys Fitbit for however many, whatever it was. Again, value proposition is very clear. The Health Promotion Board running a very large national steps challenge, health promotion challenges. Lumi Health, the partnership of HPB with Apple, right? Remarkable partnership to try and run these large health promotion challenges, promotion programs. Again, very valuable there. The question is, do we, in our mission, or even in yours, as doing development, do we have a value proposition in wellness? What are we supposed to do in wellness? We have already started a program at NTU. It's an observational study, but for interventions. What interventions should we do to transform the care, like the mental health or wellness of, like, let's say, students or in the well population? If that value proposition is not strong, then maybe we better think twice about moving into that space. Questions I still don't know the answer to. How's about in aging as well? Again, I think I have an idea of where we could have value, but again, I'm not really sure. If you have ideas, if you have papers and seen results, have your own work or know of work, yes, please come and tell me afterwards. These are things that we need to figure out. And again, I should say yes, as I've been talking about the IMH program, I think our value proposition is quite clear. If we can predict those relapses, which our data shows, I believe we can predict those relapses, can we do anything about them? Okay, that needs to be seen. That needs to be seen. As I mentioned, we have already started the wellness initiative. So HOPES is now being deployed at this Brightline study. 500 students have already been onboarded. They're about halfway through. Purely observational data collection. So we're collecting all that same data that we collected in the IMH study. But instead, of course, the scales, the measures that we're measuring against are slightly different. Some of them are mental health related, like depression and anxiety symptoms. But some of them are other interesting things, like loneliness. I've become more and more interested in trying to think about loneliness. Loneliness not in just students, loneliness in aging seniors, let's say. Stress, your help-seeking attitudes, very much a health promotion measure. So that's what this observational study is going to be studying. Again, a lot of my job, or people like me, we're going to develop predictive algorithms of that state. You know, what is the state of the student kind of as it's evolving over time. And yes, principally drive the formation of an interventional strategy, which again, MOHT must do, right? We can't just publish a paper that's, NTU can do that, we cannot do that. If we cannot design an interventional strategy that we think is going to transform care of student or otherwise wellness and mental health, then probably we need to exit that space. Again, would love to hear ideas because we put a lot of work into it, so I don't want us to have to leave. So just on that note, you know, again, there are a lot of people, again, studying it purely from a research perspective, just measuring, trying to find these associations. Even locally, you know, NTU, who is our partner here working with us, they have work already in this. SMU, we know Rajesh Balan. His big thing is passive sensing from Wi-Fi signals and trying to address loneliness in students. NUS has probably the biggest study we're aware of. That's not the National Steps Challenge. NUS 1,000 students, 1,000 staff members. It's run out of the Sleep and Cognition Lab. Mike Chi, for those who know him. So obviously it has a heavy sleep element to it. He does things like he challenges the students. He incentivizes them with HPB health points. And he gives them an incentive if they successfully get to bed within a 30-minute window every night. And then also, if you get over a certain amount of sleep, whatever the recommended sleep amount is. You know, that's an interesting, that looks like a national sleep challenge, right? In fact, I think someone should, I keep saying it to, I actually said it to Mike Chi, he should go and convince HPB to go run a national sleep challenge. Just do exactly what he did in his study, but, you know, across the whole country. I think it's a great idea. But again, you know, what's our role? What should be our role here? I'm not really sure. I want to give a bigger view of a lot of our digital mental health strategy. I cannot talk about any of them today because I don't have the time. But we did start in HOPES, this digital phenotyping project started in the high needs. If you're familiar with our Singapore National Mental Health and Wellness Strategy, they have this tiered care model. But anyways, it's in the high needs section. We also have Mindline.sg. I mentioned it earlier this is where we deploy a lot of our digital interventions. This is our digital mental wellness platform. No digital phenotyping, no sensing. It is purely just you know, resources and exercises you can use for self-management and self-care. But this is the strategy. We started at two ends and we're sort of moving towards the middle. We believe Brightline in student wellness, which is a digital phenotyping study, could be that meeting point. There are other initiatives we have lying around this mental health space. Mindline does have a clinical adjunct product delivering ICPT, that's digital cognitive behavioral therapy exercises. We have a digital peer support forum, Let's Talk. But yeah, the convergence of our digital phenotyping strategy and these mental wellness tools, that's something very much on our agenda that we have to do, quite frankly. One more vision of what this scaling out, but kind of eyeing, you know, what we have to do in population health. It has to scale across different population bases and setting. It has to scale nationally. So we started with, you know, HOPES, which is down in schizophrenia, the most severe of the mental health conditions. We branched out to, let's say, major depressive disorder and the other mental disorders, covering the rest of diagnosed conditions. Mindline SG started in wellness, right, covering by far the largest population base, but the lowest amount of need. Brightline is kind of straddling somewhere in between. They're definitely not diagnosed, but they could definitely be at risk, right? Students, if you think about students, especially in Singapore, right, could definitely be at risk. And then one place that we have moved into is primary care. So the provision of possibly mental health condition management within the primary care setting enabled by tools like HOPES, like Mindline. Very much under development though. Okay, last topic, I have a few more minutes. Last topic I want to talk about, is aging. So this is one that from the beginning, we have been told that, MOH wants us to look at, everyone actually, they want everyone to look at aging, right? It's a national priority. But a long time we just didn't really know what to do, especially because in dementia, the largest burden, the thought was, well, once you enter dementia, much of it is you can't really transform care. We hope for things like monoclonal antibodies, like lecanemab. We're very hopeful that they can have a transformative impact, but otherwise we weren't sure that we could really transform care there. Now the story is starting to change. We're seeing a lot of results out there that cognitive impairment, mild cognitive impairment, and other cognitive and physical frailty are reversible, and certainly you can prevent their progression and decline. So now we're starting to think, maybe we can start moving into this area. So one question is, okay, what about screening? All the GPs come to us, and what they ask for, sorry, this is a slide on kind of the different aspects of aging. All the GPs come to us, and the one thing they ask us for, right, we don't ever develop something without a clinical partner asking us for it. So the GPs always ask, can you give me like a screening black box? So I have all these patients that come in and they might have some symptoms of memory, trouble with memory, their walk is funny. But actually all the assessments for dementia or mild cognitive impairment, early dementia, all take too long. Or actually they're a bit not precise enough that you can't really take just one measure, right? You gotta take one measure, maybe have them come back, take it again. So can you just give me this black box, like your digital phenotyping black box? Slap a Fitbit on them, install your app on their phone, send them home. They use it for 2 weeks. You have a machine learning algorithm that comes and predicts whether or not they have MCI, what stage of MCI they're in, or if they're in dementia already. We have been looking around. It turns out, from my view of the literature, and maybe people are in this room that know better than me, but no, it turns out that this is not something that people have been able to develop. People have tried. It seems like no one can really come up with a biomarker from these devices that can make this prediction. So maybe not for us to get involved. I don't know if we want to be the ones to make such an algorithm. I mean, SEC, right, is a strong, deep science and engineering research organization. Maybe you guys want to go and find that algorithm. So maybe screening. I'm not sure. I'm not sure this is where we should go. There are other options. In fact, this geriatrician Tao Ming Liu in the Memory Center at SGH came and gave us a nice talk about a new system he's developed. There's a blog post and a Nature paper he published about it, about a new system he uses on an iPad. So actually one of the classic tests for dementia is, right, they tell a patient draw a clock. That's basically what the tests are like on an iPad. And what he does is he goes to the void decks of HTTPs, and they just like flag people over to come and do the test on the iPad. And if a signal comes up, they try and refer them. So there are other options in screening, bear in mind, other than digital phenotyping. But what about just monitoring and intervention for delaying the progression of cognitive impairment, or maybe even reversing? We do know it's reversible. What are those factors driving reversion? I'm not really clear on. But maybe that's the strategy we need to go into. I think right now, my sensing is this is probably where we need to go. And we do have activities. If this talk was being given just 1 week from now, I could tell you a little bit more. But we do have activities that we're actively moving to start working in this. How it's going to pan out, though, again, I really don't know. Okay, returning to this vision of trying to complete this circle of health determinants and what digital phenotyping plays that role in. Well, if I just sort of take this circle and I sort of lay it out along the bottom of the different determinants of health, and by the way, different large national data sets that we do have available. As researchers, you can go and try and access this data if you really want to, right? Our 100,000 genotype sequence genomes of the population. Gusto, largest birth cohort in the world. Mike Winnie, we talk with him a lot. We really want to work with him. our study and the other digital phenotyping studies, National Steps Challenge, a maternal study, silver generation, all these different large data set. Helix, probably one of the most comprehensive coverage of a EHR, national EHR in the world. All of these things, you kind of look at the map of factors of what they can measure and determine for you, and where not only you can measure, but intervene, what your intervention path looks like. This is not from a paper or anything. This is just purely my own. I one day drew this graph and even these islands myself. So don't, there's no citation and don't quote me. I know there's things that are not accurate here, but just giving you an idea. Yeah, for each one of the conditions, there is a mapping. There is some multivariate holistic data set mapping across sensing and intervention that are driving these determinants of health outcomes, right? Preventive care, maximizing human health and potential. That's across the majority of your population. Chronic diseases controlled, aging well. These are all things that we believe, if you just look at the size, I drew the size proportionately. Digital phenotyping measuring the behavioral determinants, they must determine a majority of this map, right? They have to have a huge role. So in other diseases and conditions that I haven't even spoken about, what I would love to see is, what are the other big ideas? We developed all this technology and this IP. I really want to use this asset where it's valuable. So I would love to invite people to give me ideas. If you have ideas, you have evidence, of studies around the world or a good amount of reason to believe why we should be using digital phenotyping in whatever your pet project is. I would love to hear it. So please come and talk to me afterwards. And that was my invitation to you, and I think I'm now done. Yeah.
Welcome to the future.